Yeah, and I do see that Paige Clarkson is
Yeah, it is.
sorry, is in the Zoom meeting with me because I have it logged in my computer as well, and it's only me and her, so I don't know if there's two different links or whatever, but we'll figure it out. So, you know, I just want to welcome everybody to the May 27th, 2021 Alcohol and Drug Policy Commission, and call us to order and remind everyone that this is a public meeting and it is being recorded. And then I will pass it over to Dr. Richardson, our Executive Director, for roll call.
Thank you, Chair. We have our newest member, Jill Archer, who's joining us for the first time today. Jill, are you on the line?
I'm my husband.
I'm here, thank you.
Hey, Jill, would you mind just telling the other commissioners a little bit about yourself?
Sure. Hi, everyone. Jill Archer. I currently work at Care Oregon as the Vice President of Behavioral Health. And previous to that, I have worked within the counties, both Washington and Clackamas, overseeing the behavioral health system for between those three, almost 20 years. And have, you know, we're currently doing quite a bit of work in the substance use treatment system. And so I'm really excited to have the opportunity to be a part of this work. So thank you.
Well, thank you and welcome to your very first meeting. It's taken us a long time to get you here, so we're glad that you are here, and you'll get to meet the other commissioners in a moment when we finish roll call. So Jill, Commissioner Archer is present. Commissioner Anderson, he is going to try to make it, but he's the only provider today at Kaiser in their department, so he may or may not be able to make it. Commissioner Cruz.
Present.
Commissioner Mazziotti.
Present.
Commissioner Holton is excused today. Commissioner Huppy.
Present. Good job.
Thank you. Thank you. Commissioner Minty Morris. Commissioner Minty Morris.
And she contacted me and said that she may not be able to make it today.
All right, thank you. Commissioner Godwin.
Here.
Welcome, thank you. Commissioner Neeson.
Here.
Vice Chair Galliran.
Present.
Welcome. Commissioner Clarkson. Commissioner Clarkson.
Reggie, Dr. Richardson, I opened up the Skype meeting app. There's a Skype meeting app like in the calendar invite, and I see Paige Clarkson and Pat Garrett are both in there, and I'm communicating with them through the chat, and they can't hear us. So maybe if we could shoot them the email with the link to get on to this.
Heather, can you?
We're using now, Teams.
Okay, thank you, Chair. Heather, can you help us? Can you please reach out to the folks who are in Skype and invite them to come over?
Yes, you said it was Paige Clarkson and I'm sorry, who else?
Pat Garrett.
Pat Garrett. Okay, thank you.
Commissioner, well, Tony, you're here, so I will mark. We do have a quorum based on the actual number of commissioners that we have currently. We are down several spots, so we do have a quorum. I'll turn it back over to you, Chair.
Okay, thank you so much, and thank you everybody for coming today. The first action item today for us, I'm going to facilitate, and I just want to start off by, saying that I'm very honored to be in this position. It's very important for me to recognize, all the work of the people who came before. me and who are on this commission, and I just see myself as a continuation of that. I want to say that, you know, Oregon needs this commission. It needs it really bad. Oregonians need each member of the ADPC because the system is disorganized, underfunded, and we could use more leadership on moving the dial with substance misuse. But, you know, we have a great plan that basically accomplishes two things if enacted, and that's decreasing substance use from happening, the prevalence of it, and increasing the rates of recovery in a thoughtful, comprehensive, inclusive, and pragmatic way. You know, in executing this plan, it is the right thing to do. It's not the easiest thing to do, but it's going to take, you know, our collective effort and strategy. So one thing that I thought we could do, especially now that we're starting to come out of the pandemic and things are starting to settle down, is organizing a retreat to create a plan to implement the plan. So, you know, it's a P2P, a plan to plan. And I know that the last thing people want is another meeting. But I think if we want to get this plan enacted and do something, you know, really, really meaningful, then we should all get on kind of the same page and strategize. You know, the last 14 months have been really erratic for a lot of people, and we've been pulled in 100 different ways, and I get that. And I think, you know, maybe get a little retreat going and get us all on the same page, select some action items, et cetera, et cetera. You know, and Reggie's one person with some great staff, but the ADPC, the charge is immense, you know, both in scope and in importance. So my pitch to you guys and what I want to discuss is, are you open to doing a retreat in general? It would probably be after the legislative session, I assume, and depending on, you know, regulations around COVID, meeting in person or Zoom, those are things we'd have to figure out. But I just want to have that discussion with you guys. Is that something that you guys would be interested in doing?
Tony, this is Don Mazziotti. I'd be very interested in having a session where we could get together and prioritize our action under the plan.
And depending on your recovery, we might have to have it at your house.
Well, we have a big backyard, a very big backyard.
Okay, so Don, you're down. Other commissioners, you guys want to chime in?
This is
Laura.
Catherine.
I'm open. This is Laura Nissen.
Hey, Laura, thanks so much.
I'm open to it as well.
And did we get Pat Garrett over here now and Paige?
Yeah, Tony, thanks. Pat just joined.
Cool, Pat. Pat, I just basically proposed that as a commission, we have a retreat to plan to implement the plan and create some strategy and action items here in the near future after the legislative session. And just wondering if that's something you would be open to.
I'm on board.
Okay, and did we get Paige?
I emailed her the new link, but I haven't seen her come on.
Okay. Is there anybody who would be opposed to it or hesitant to do it?
Tony, this is Judge Block. I just want to, I'm not opposed at all. I was just deferring to hear from other commissioners, but not only am I willing, but I think it's a great idea. I think it's a very important next step to prioritize and get sort of focused on the commission's work. But I also think it'll be a great opportunity for us to learn how to work together better and get focused on how we become the most effective commissioners we possibly can be. So I really commend you for putting this forward, and I'm 100% supportive.
Awesome, and I would love to take credit for it, but it was actually Reggie who proposed the idea. I had suggested that maybe we have a discussion in this meeting about getting on the same page, but Reggie had suggested this instead. And Reggie, you had said something to me around the ability to have more meaningful conversations with a retreat. Is there anything you want to like expand on that for the commissioners?
Sure, thanks, Chair. for some of you who were part of the commission when we had our very first retreat, Laura Neeson was helpful in getting us a space on the campus of Portland State University. And it just was a great time for us to build team and support among the group and to really focus. That was when we were about to start the process of our strategic plan. And I think it helped to focus us. I think we had, an opportunity to spend time getting to know each other. It was facilitated. We had good food, and I think it was just a good time to come away and spend the day about our business. So I think that it's time for us maybe to do that again, so that we can really focus up on the things that we want to move forward on. And I don't know if any of the other commissioners who were actually on the commission at the time we had our first retreat would like to speak to it. Thanks, Chair.
Yeah, thank you, Dr. Richardson. Okay, so let me ask you guys this. Is this something that you would rather do in person? And I know, like Nate, you've expressed to me the importance of including the rural perspective in what we do. So I want to make sure that we can accommodate, commissioners who are outside of the metro area. So is the in-person thing something we want to do? Because we may, sorry, somebody called me, but is that in-person thing something we may want to do and wait until that's allowable, or is it something that should be more immediate after the legislative session? You guys have any, beliefs around that or desires around that? Does it matter to you?
I think in person is great. It's a lot easier to actually network and discuss things when you're not sure when you can actually see who's talking and break off groups and things like that. I'm speaking for myself with this, but I'm sure that other people in Southern Oregon would also agree. If we could have something a little bit more centrally located, maybe like Eugene as opposed to Portland, that would be appreciated for those of us, in the southern half of the state.
Totally hear that. Noted. So I got one in person, one at the Hilton in Eugene. I'm just kidding.
So Tony's a Judge Block. As somebody who's lives and works in the metro area, I'd appreciate it if it were out of the metro area. I think it would be not only a good accommodation for folks who have to travel here for meetings far too often, but I think it's a nice opportunity for us to get out. I think it's got to be in person, my view, because and it sort of plays into another point that I wanted to just raise. Retreat the retreat, and I'm not the commission's legal counsel, so this is not to be taken verbatim or in an authoritative way, but I think we need to sort of get a pre-clearance on this so that we stay on the sort of the right side of things. I think the exception to the public meetings law that relates to retreats is really about us getting together and working on how the commission functions, how we relate to one another, how we know one another. It's a lot about that. And I think all of that necessitates us being in person. I think otherwise it's just not going to be nearly as effective. And in terms of some of the other work about sort of prioritizing and all that, again, I'm not, the authority on this topic, and I think there is not a bright line, or, to put it another way, some gray area that does allow us to do some of that. But I think we have to be careful, not only to stay on the right side of that line, whatever it is, but also because as a commission, we're very invested and wedded to the concept that, we have to have stakeholders, be present for and participate in, meaningful commission conversations and deliberations, so that we have their input and there's that accountability piece. So bottom line is, I think it's really important to do this, important to do it in person. We do want to make sure in terms of the legal constructs of the public meetings law that we have the agenda properly enumerated.
Yeah, sounds good. And we'll be prudent about that. Is there anybody who would prefer a virtual meeting, or at least access to, virtual option, hybrid, something like that?
Hi, Tony. This is Paige Clarkson. I'm by phone, and I'm about to say that I like a virtual option, despite the fact that the virtual option did not work at all for me today, hence the reason I'm on the phone. So I could not get into the Teams meeting. It just keeps glitching on me. But from my perspective with my calendar, I am much more likely to be able to participate and be present, especially when there's decisions and voting discussions and quorum needed. I'm much more likely to be able to participate in that when there is a virtual option. It doesn't mean I don't want to see you all, because I do, and I'm happy to try to get there when to locations when I can. But sometimes my local obligations just make it difficult for me to spend a lot of time on the road when I have a million other things just in my own jurisdiction. So I love the virtual option because it does give me an opportunity to really participate and stay in the know, even if I can't be there every single time. So that's just it's great to have that option for those of us that want to be involved but maybe can't always make it there.
Okay. Noted. So let me ask Dr. Richardson if this would be okay with him and his staff time. Maybe as an executive committee, we get together and kind of brainstorm, look at some possible dates around when we project would be the most feasible for in-person. And then we can come back at the next commission meeting and propose something.
Okay, that sounds great. Hey, Chair, it looks like Commissioner Cruz has her hand up.
Oh, sure. Yeah, I didn't even see that.
Yeah, I'm not really sure. I'm not really sure where it's at, since this is a new system that the state is using. But some of us have restriction of travel, and I think, yeah, the later it is, so we can make sure that our numbers are down. I see that we might be, lifting the restriction probably within the next month or so. So I would recommend like a July or even possibly August time, because I think by that time, many of us, hopefully, our protocols will be revised by then. I know we're trying to start opening up to the public starting the 7th of June, but we still have restriction of travel. And I am a very visual person, and I know we make these virtual meetings work, but that's not my preference. I really like to be in person. I like to see people's body language. I like to see their facial expressions, and I like this open ability to discuss things openly. And so we make virtual meetings work because that's our only option right now, but I prefer in person, and hopefully maybe July or August, so when we could have a better, I think, understanding vaccination numbers are a little bit more up by then, and we could start traveling.
Totally. Yeah, thanks for that input. I really appreciate it. Right on
Chair?
board with you. Yeah, go ahead.
Yeah, the governor hasn't lifted the prohibition for traveling for state employees yet. And
Okay.
The latest information we had, it looks like it might be August or September, or I'm sorry, September or October before that happens. We haven't gotten an update yet, so it would have to occur once that has been lifted. And I think Judge Block also has his hand up.
Go ahead, Judge Block. Thanks for that, Reggie.
Sure.
Yeah, actually,
Go ahead.
I guess my comment was my question related to if it would be helpful for commission members to forward to Dr. Richardson and the chair any vacations or dates that we know that we are unavailable in the next, and I didn't know exactly what the time period was. I was going to suggest maybe July and August, but Reggie, in light of what you said, maybe dates through October that were unavailable. That's just a thought.
Yeah, we may do something along those lines, send out a doodle poll or whatever.
Right.
We'll figure out the logistics around it. We just wanted to make sure today that this is something you guys were open to, wanted to do. I think it was a really great suggestion by Dr. Richardson. And I think we have a lot of work ahead of us, and I suspect that the next legislative session will be heavy with things that we're trying to push forward and manage, and a lot of opportunities to interject our strategic plan and the important components of it, and getting on the same page prior to that, making commitments, friendships, communications outside of the commission, just to get work done. It would be really important. So if there isn't, any other further discussion, then I think, Reggie, do you have everything you would need to kind of move forward with you and your team?
Yeah, we'll take it up at our next leadership meeting and map out a direction. So yeah, we're good. Okay.
And we're a little ahead of schedule. Is Joanna Johnson here by chance? We'd be able to get started a little bit early.
She's here, and Joanna, you're ready to roll?
Yeah, I can go.
Do you have slides you're going to present?
I do, and I just emailed them to you to send out. I apologize. It's been a very busy week, and I forgot to send them to you. So my deepest apologies. I appreciate your patience. But so we could provide those to the commission after the meeting. And also, I'm also here representing Nicole Corbin today. She had a death in the family, so I'll be here for the whole meeting.
Great. Welcome. Thank you, Joanna. Are you going to present your slides?
I can do that. Let me just pull them up. Can you guys see them okay?
Yes.
Okay. Thank you so much. And can everyone hear me okay? I gave a presentation earlier and there was some trouble with my audio, so I just want to confirm that you can hear me.
Yes, we can hear you.
Good.
Okay, perfect. And
also, if you're not speaking, if you can mute yourself, please.
Thank you. And if I could have someone help me monitor the chat and or hand raising, I can't do that and share my screen very well. So feel free to interrupt me.
We got you, Joanna.
Perfect.
Go ahead.
Thank you so much. So hello, my name is Joanna Johnson. I know many of you, and I've gotten the privilege to work with many of you. Some of you I don't. I am the Substance Use Systems Coordinator and current 1115 Waiver Demonstration Manager. And I work under Nicole Corbin in the Behavioral Health in the Addiction Treatment, Recovery, and Prevention Unit. And so today you might be like, why is Joanna here to talk to us? And if you look on your agenda, it'll say SUD 1115 Waiver Demonstration is my guess. And you might be saying, what is this? Why is this important to me? And I hope I can answer those questions for you today. So first and foremost, we submitted our application to the Centers for Medicaid for the SUD 1115 demonstration application last May, and it just got approved April 8th, 2021. So it took a little bit of time to get that approval. I mean, we only had a pandemic and several other things going on. So that went into effect April 8th, and we're kind of getting in the process now of standing up this 5-year demonstration. I'm guessing that many of you are familiar with this or partook in some of the feedback and different activities we had going on. This was around a 6-year project, I think, to get the application submitted to CMS last year and the approval. So hopefully it won't be completely foreign information, but if you have any questions or aren't familiar, if someone's like, what's a waiver? I'm more than happy to give a little synopsis. Mostly we're just asking permission for things we don't have authority to do in our OHP Medicaid system. And this waiver is only for substance use disorder. I say that, I'm going to keep emphasizing it because every time it even I forget sometimes, am I talking about all of behavioral health, but this is just for the substance use. So this demonstration has 3 different levels of activities. So the first one is the actual SUD 1115 waiver itself. And then we have some activities that are related to an implementation plan, which these are the milestones that OHA has to be making or working towards to be able to apply for the waiver. And then we also have our state plan amendment, which I'll also talk about, which is the things we already have authority to do. So we don't need to get permission from CMS to do those things, but we haven't been doing them. And so those activities are going to help increase our continuum of care here in Oregon for those with substance use. So kind of why are we applying for the waiver? Why did we do that? So we in Oregon, we really want to create this full continuum of care. And this is just one of the components that we're using to get there. So our goal is to have access to services before, during, and after treatment. So the big question was approved in the waiver, and what are we getting for this? So the first thing is the Imb exclusion. And what does that mean? So CMS says that you can't use federal funds from Medicaid or Medicaid match funds for individuals staying in an IMD or a residential facility with greater than 16 beds. So we have that waived now. So as of April, I think it'll actually start May, Oregon's eligible to be receiving matched funds from CMS for stays in facilities with greater than 16 beds. And prior to this, so Oregon already had this as part of our system. We valued it. We were paying for each of those stays entirely from general funds. So this is kind of a big deal for us. And the exciting thing is that we have kind of had a limit on the number of providers we could have that had residential facilities with more than 16 beds for substance use because we've been paying from general funds. So there's just a limited amount of funds to pay for those services. And so we're going to be removing that, and this will increase capacity of services so that providers can get licensed for more beds or new providers can get licensed. So that's kind of a really big thing. I don't know exactly the time frame for that. We're working on standing that up. We have up to 24 months to stand up all of our activities, and each activity is on a different time frame. So that's very exciting for the first thing. The second component of the waiver is what we're calling community integration. So this we're planning to stand up January 2022, and that is providing housing support services and employment support services for individuals transitioning into the community from residential facilities and then maintaining their integration into the community. And this is really intended, it's not rent, it's not deposits, but having someone to help communicate with the landlord or find and seek housing and or employment, which can be a really big deal just to have that extra resource. And we are it's meant to supplement services that are already existing. So if someone, for example, qualified for VOC rehab services, we'd really want them to go get those services because they're going to have a more comprehensive and more resources. So this is meant to expand those services and access to support around that. Are there any questions so far?
Yeah. Joanne, this is Tony. So is this like, let's say you have an employee at your organization and you can now bill Medicaid if that employee is helping somebody get employment or helping somebody get into housing? Is that what this means?
I think it depends.
Okay.
So if you're a provider, we haven't written the guidance for this, Tony, so this is just me spitballing from my hip, okay? Don't take it as like this is exactly how it is, because we still have to write these guidances. But it would be you're able to bill Medicaid to, let's say, have I think a peer, I think it can be, I'm trying to remember all of the individuals that can do this service. It could be a QMHP, someone like that who's supporting housing services. So this would be like a billable service, if that makes sense.
Yeah, like I'm supporting somebody in a recovery house and I'm a peer, and now my agency can get reimbursed for that service, where previously that wasn't happening.
Right. Yep. So
okay. That's really good.
Yeah, and like I said, the guidance on what that looks like is going to be written in the next 6 months or so. You know, it's still kind of up flux exactly what it means, but there is, Tony, in the STCs on our webpage, which I can put in the chat, a link to that when I'm not presenting, or people can Google SGD 1115 waiver Oregon and go to our webpage. The STCs, the special terms and conditions. So this is what CMS has approved for us. In one of the attachments, I think it's the last one, I want to say it's like page 42, but don't quote me on that. It actually lists out like what services can be provided and what the medical necessity is to receive those services. And so that's what CMS approved.
No, thank you. Is there anyone else who has any questions about this particular part?
I do. This is Kat. In terms of the 16 beds or the funding for greater than 16 beds, just kind of curious how that number was arrived at, since some more rural areas may just not have facilities that big. And then that, you know, it's a pretty frequent complaint of the rural communities that the cities are getting all the funding, and this seems like another situation where that might inadvertently happen.
Yeah, no, that's a great question. Thank you for that. So actually, this is a federal definition. So they have, it's like Institute of Mental Disease. And so they decided, I forget exactly when, I used to know all this stuff, but they weren't going to fund any facilities that had more than 16 beds. And so that's totally not our decision. So they've been funding beds that are lower than that, any facility. So we're just asking that we be able to do the larger facilities. And so in the rural communities, it may be an advantage in that they're able to add more beds versus having to build a new facility that's under 16 beds, for example, if they couldn't get it licensed. So it just kind of depends on the situation, but we're hoping that it actually will open up opportunities as opposed to reducing them. Does that answer your question?
Yes, it does. Thank you.
Yeah, no problem. Any other questions? Okay, so I'll just kind of go on to the next thing. If anything comes to your mind, feel free to, we can always go back to it. So feel free to ask. So the one thing that we asked of CMS that we did not get approved was what we were calling recovery support services. And so this was, our ask was that we could provide peer-delivered services outside of a treatment plan. So currently, as many of you know, probably more than me, we offer peer-delivered services during treatment under a service plan. And so the two components we asked CMS to do this with was one with current providers. So they could have a peer that interacted and reached out, did outreach and engagement before, during, and after treatment. And so that'd be anyone who currently has peers that they're billing for or working under them. There was the current provider type. That was the first ask. And then the second ask was that we create a new provider type, and that would be peer-run organizations. And then these peer-run organizations would be allowed to bill Medicaid independently for their peer activities. And the peer-run organizations, as you know, I mean, many of you know far more than I do, but not everyone comes to recovery through treatment and clinical services. And so this would allow an opportunity to receive a consistent funding source from Medicaid and bill those who have OHP and those peer-run organizations that want to become certified as a OHP provider. And so CMS was like, oh, this is great. We love this idea, but we have a lot of questions and no one else in the country is doing this right now. And so they put a pause on it so that we could push everything else through, and we're going to continue conversations and talk about this. I think there's also lots of conversations about broadening the scope to be not just SUD. That's outside my scope. But I hear kind of conversations. So we don't know exactly if or when this would be implemented, but it is an option for us to continue conversations with CMS and then add as an addendum later or an amendment to our current waiver. I think there are many people probably on this call who helped provide feedback on this section. Does anybody have any questions? Nope. Okay. So just some other requirements you might hear us talking about. We are required to do an external evaluation, and we've hired OHSU, their community health systems of excellence or something. Sorry, I'm really bad with acronyms, but they're going to be doing our external evaluation. And then we have a statewide substance use PIP for the CCOs that will start in January 2023. We're participating in the federal evaluation, and then we also have a quarterly and annual CMS monitoring reporting, just like our OHP 1115 waiver. And so all those reports and evaluations will be available on the website as they come up, just so you can monitor it if you want in the future. So the implementation plan, like I said, this is actually in our STCs as well, the approved implementation plan. So you're welcome to take a look at it. It's kind of lengthy. It's one of the addendums to the STCs. So we have 12 to 24 months to implement these activities, and these are activities we have to meet these milestones, like I said, to apply for the waiver. So some of the things that might be important, we're going to be working on a quarterly report for internal quality improvement. We have to create a mechanism to ensure CCO network capacity for substance use disorder. And so there's already some CCO work going on, so we're going to align our work with them. We're going to be adding ASAM levels of care to provider licensure and certification. So what that means is that, and this will probably be more on that 24-month implementation. So January 2023 would be when you want to start looking for a lot of these things. But each facility will be licensed at ASAM level 3.1 or 3.4 or multiple levels. And then when someone gets their assessment for ASAM, we can direct them to the appropriate level of care and facilities that have that level of care capacity. And then we are doing our behavioral health IT plan and PDMP metrics. We are going to be encouraging CCOs to get technical assistance for substance use topics like naloxone use. And then we're going to be working with OEI. Some of this I think was already underway, but to develop some culturally specific trainings, specifically for the tribal and Latinx community, but hopefully expanding that beyond that. So are there any questions? There's many more activities. I could probably fill a whole PowerPoint with just the activities, and I think it would be kind of boring. So does anybody have any questions on these things? Nope. Okay. So
I think it looks like, did Sam, did you raise your hand?
I did, thank you. Joanna, I just had a quick question on the peers, and it's more clarification. Mm-hmm. Is it that Oregon is so progressive with peer work that we have to demonstrate that it is best practice? Or is it that they want to see that our best practice has, produced some kind of result? Because I know peers are used at a national level, and so I think that kind of clarity will be important for the vision and plan for Oregon in terms of how it begins to, collect data related to peers. And I know that Chair Bazina would have more information on that than even me.
No, Sam, that's a great question. So this particular metric actually, I think, was produced by Oregon when we were doing the application. This was, gosh, it would have been fall 2018. So before it was kind of a culturally specific and responsive work was it wasn't as elevated as it is now. And it was part of our work around doing the peer delivered services outside of the treatment plan. And I think this is one of the only metrics that stayed, just because we wanted to make sure we're pushing that forward. So I don't know that it came from them. I think it was generated by us.
Thanks, Sam. Thanks, Joanna. Are there any commissioners that have any questions about this? So I do have a question, and as we expand services, or the ability to get services, increase services, is there any targeted efforts to ensure that capacity is being built out in service areas that really need it versus being concentrated like in Multnomah County, or make sure that culturally specific providers are being given the tools they need, the encouragement that they need to develop their own programs. So have you guys thought about any of that and how you might go about that?
Yeah, Tony, that's totally come up actually in a lot of the development conversations. I think when we're looking at implementation right now, the focus is just standing up these programs and making them available to everyone. So ensuring that we have all the guidances out and people can bill appropriately, and that the CCOs, it's in contract, and that they have the information. And then kind of going on from there, I think we do have, we need to create a report for internal quality improvement. And I think that that'll probably be a part of that when we're talking about CCO network capacity and ensuring that. I think that there will be some of those conversations. I don't know that there is a specific metric that we're going to be using to measure that at this time. But I do think it's in our awareness, and will hopefully be embedded in all the work we're doing.
Okay, thank you. Do any of the commissioners have any other questions? Jill Archer, go ahead.
Hi, thank you. I was just curious, Joanna, if there's any funding that might be available for like the capital investment in new capacity.
Not to my knowledge. So I think a lot of this, the funding that we're getting from this waiver is mostly match funds. So, and the authority to do things. So we're not getting like a large sum in terms of just kind of money that we can delegate in that way. It's really matched. So all the services I'm listing, we're getting match fund for those, as opposed to just getting a chunk of change to divvy out to do that work.
Okay. Thank you.
Yep.
Yeah, and thanks, Jill. And then Judge Block, did you want to chime in? I seen your hand up.
Yes, thanks, Tony. So I wanted to ask Joanna on the waiver that now allows for residential facilities over 16 beds to access Medicaid funds, which is great. And I hear that one of the reasons why the state was seeking that waiver was to try and make it easier overall for us to increase capacity and have more residential beds. And so this does make it financially more easier or more feasible is OHA doing anything else to facilitate and address other barriers that are getting in the way of us increasing the amount of residential beds that are available statewide?
So that's a great question. I know there's lots of work going on by many of my colleagues that I'm not quite in touch with. I've been really focused on this particular thing, and so I can't speak to what they're doing. I can say that this will increase access. Like I know our licensing and credentialing units already gotten questions about when people can start licensing for more beds, and so we're getting the plan out to them shortly. And so I can't speak to what my colleagues are doing, but I do think this will provide opportunities in and of itself to expand residential services, and that several facilities are currently looking to do so.
Okay, that's good news. Thank you.
Mm-hmm. Any other questions on this? Okay.
So just one more question. So high level net gain, like if you were going to say this waiver is going to equal 3 things, you know, how would you describe that? What would be those 3 things, or some net positive that was going to happen as a result?
Yeah, I think that there's going to be access to eventually access to residential beds and treatment statewide. I think it's going to open up a lot of opportunities for that. I think that it's going to provide a wider breadth of services and parity with mental health. So I'm going to talk about in a minute the state plan amendment and some of the activities that we're adding and rate increases that are going to come along with that. And then also, I think the final thing is that we've planted seeds in CMS and discussions around changing the way we think about delivering services like peer-delivered services before, during, and after treatment. And I think started a lot of those conversations that'll hopefully lead to gains in the future, whether that be through this waiver or other waivers in the future.
Yeah, thank you. And then do you have more slides?
I do, yes.
Okay,
Sorry,
okay, we have 10
more.
minutes. No, okay,
Yeah,
cool.
Sorry, sorry if I'm going over. I'm trying to be
No,
quick.
we're good. No, I'm keeping
Okay.
us on task. I got you.
Thank you. I appreciate it. So the other thing is the state plan amendment. So this is things we already had authority for, and we're going to be adding them as services, covered benefits for our OHP members. So the first is brief intervention services. We have, it's actually restorative case management, crisis intervention, skills restoration. It used to be called skills training. And then we're also looking at, or we will be doing some rate increases. So currently, many of these services are offered for those with mental health, but not substance use disorder. So individuals who have a mental health only or co-occurring are able to access this, and we want to create some parity, and hopefully also there'll be parity in pay across the continuum. So regardless of what people are servicing or what their diagnosis is, they can receive the help that they need. And also the skills restoration will also be able, just that one will be able to be provided by community health workers. That was a request from some providers in the rural areas because they want to use their peers for peer work, and they have a harder time recruiting them. So they requested that we add that on as another type to be able to provide that particular thing. Are there any questions? And we should be submitting that, I think, in the next couple of weeks. And so these we're planning on also having available January 2022, along with the community integration, the housing and employment. Are there any questions? So next steps, state plan amendment to CMS, and then we'll just begin implementing waiver activities, and you should see those, like I said, January 2022. Also, we're going to be we have an advisory committee hasn't met since we submitted the application. So I'm going to be sending out some emails about that to individuals who were participating to see if they still want to continue. But if you're interested, our first meeting will be in early July, and then we'll meet every other month for a while, and then it'll be quarterly and kind of go on like that. So if you're interested or you know somebody who'd like to participate, please let me know. And we're going to start implementation activities. So if you have any questions, feel free to email us. And are there any other questions now?
I have one question, but I think we have Heather Jeffress on. And Heather, I was just wondering if you are on, if you'd be willing to give us some perspective from your membership on what this state plan could mean for you guys.
Well, I think there's some pretty exciting things here, and I have to say a huge thank you to the team at OHA and their collaborative work with our association and other provider associations in the state in really working together to do system improvement and address some of the longstanding and now more urgent challenges that we face due to the COVID disaster. So, so thank you, Joanna, and to all your compatriots over there for doing these things. And I think that between all of the different opportunities that we have now with the waiver and with some current legislative work, the various rescue plan buckets, the next 2 to 3 years are going to be quite pivotal for our sector in how we can leverage these opportunities with some of the challenges that we have at hand. So, that's just a really broad statement, Tony. I apologize for that. But I think, there's always pros and cons whenever you get an opportunity, and there's things that will get lifted and then there's things that will not. And I think, a real simple one that you guys talked about quite a bit here was the IMD waiver. So that is fabulous, and providers have been, needing that for years, and that will really help the state's general fund, right? Because this will allow the state, as was mentioned, to really invest a smaller amount of money into beds and receive a much larger percentage from the feds. So overall, the money will increase. So when we go through these ups and downs with the budget cycle, the system will be less impacted because it will be less tied to general fund accessibility and appropriation. So it's very exciting. It will be very stabilizing. And yet at the same time, while we also have other monies coming in right now, and I'll talk more about that when it's my time, we face some pretty serious challenges around the workforce. So it will be a very interesting time and excellent opportunities. And all of these opportunities, I think, can be woven into really doing some great work around lifting access and equitable access, particularly across the state of Oregon for a variety of services. Is that helpful? Sorry.
No, I think it is. I mean, I think it's just helpful to know from the provider perspective what this means, and thanks, Joanna, for all your hard work. And I know we've went back and forth about stuff in the past, so appreciate you guys. The question that I have is around the rate increases. You say it says some rate increases. What are those rate increases? Because I'm a little worried about inflation, and then us being able to pay people and recruit them to stay in the field, during this time. So can you just talk more about the rate increase real quick while we have 5 minutes?
Yeah, I can. I don't have the exact numbers off the top of my head, but I know that, for example, residential facilities have not received a rate increase for like a significant one for some time. I think they just got like a really small one like last year or the year before. But so those will be going up, for example, and then like making sure that case management is the same between mental health and substance use disorder. Making sure like all of the services are matched in that way. So if it's higher for mental health, we want it to be the same to pay for those services. So I think it's more like if you're, let's say you're on the open card and your billing fee for service, you'd have a higher rate. And so the thing about that too is a lot of the CCOs, it's not an official thing, but it's kind of like the minimum that CCOs will pay. So theoretically, right? So it's like a recommended minimum, and so hopefully that'll provide kind of a higher standard for pay across the CCOs. So that's kind of the goal. And then like for those who do fee for service, it'll give them a good bump. I don't know what the numbers are, and they're already old, right? So we wrote this in 2018 and now it's 2021. So, you know, hopefully there'll be a little bit of adjustment there, but I don't know that there will be. So it's just, these things take such a long time to go through the system.
I know they do. So thank you so much. There's a few minutes left. I just think summarize by saying it looks like, some of this plan, or the SUD waiver actually fits into our strategic plan, increasing access to, treatment services and potentially, recovery supports, including housing.
Yeah.
Any last questions by commissioners? Reggie, anything you want to add?
No, I'm good. Thank you. Thanks, Joanna, for updating us. We look forward to seeing how the implementation takes shape. I'm good, Chair. Thank you.
Okay, well, thanks. And Jill, are you ready?
I am. Thank you. So I know we have a couple newer people to our commission meeting this month. So just to make sure everybody knows who I am, my name is Jill Gray. I'm one of the analysts for the Alcohol and Drug Policy Commission. And Dr. Richardson asked me to talk to you today about a handful of bills. I have some slides that we're going to go through. If anybody would like to access these slides after the meeting, they are on our website. They're in the agenda materials section for today's meeting. And Joanna made this look so easy, but hang tight with me as I try and fumble my way to bring up these slides.
And if I could just hop in real quick. Thank you so much, Jill. Jill's our brilliant analyst and always keeps us up to date on all of the nuances. But what I want to say before we get into it, is that the commission basically can do things collectively on our own, right? And then we have our individual commission hats where we have legislation that's important to the commission and important to our plan, and then we can go outside of the meeting in the commission and we can go lobby and advocate on our own behalf. And I would like us to think about how we could support the commission's efforts individually today. And I'm more than happy to hop on a call with anybody and help write an email or talk to a legislator, offline. So I just want to put that out there and encourage the commissioners to think about that.
Okay, so I'm having some technical difficulties. Tony and others, let me know. Can you see my slides?
No.
We cannot.
Okay, hang on. I said I'm still learning about Microsoft Teams, so let's see.
Looks like you got some TA in the back. That's nice.
I do. I have my at-home technical assistance. Everybody should have that.
Okay, we're good to go.
Okay. Oh, nope, that wasn't what I wanted. Thank you.
Wait, no, you're already in presentation.
Oh my goodness. This may take more than my 15 minutes of allotted time on the agenda. So we're just gonna go forward even though this isn't gonna show you the whole entire slide. Okay, so Dr. Richardson asked if I would briefly describe to you the bills that were introduced this session that reference or mention the Alcohol and Drug Policy Commission. There are about 5 bills we're going to go through today. If you have any questions, just please interrupt me as we go along here. And otherwise, I'm going to just keep talking because I know I have a short amount of time on the agenda. The first bill we're going to talk about is House Bill 2086. This, as you can see in the first bullet point, is OHA's behavioral health bill. This is a really large bill that has a lot of content in it. We've talked about it a few times in the Public Affairs Subcommittee and have at times called this bill OHA's behavioral health omnibus bill because it has a lot of pieces in it. The two pieces that we have been particularly interested in have to do with co-occurring disorders. So there's a section in this bill that says treating co-occurring disorders, that the reimbursement rate would be at an enhanced rate. It also says that OHA is going to conduct a study on just how to better address treating co-occurring disorders and make recommendations to the legislature, and some other items having to do with co-occurring disorders. Another section of this bill that we've been particularly interested in has to do with housing. Currently in statute, OHA is limited in how it can use its funds regarding housing. It specifically says in statute that those funds have to go to alcohol and drug-free housing. This bill would remove that abstinence-only language and would allow OHA to use their funds for all different types of housing. Besides those two sections, there are many other sections, one of them having to do with workforce, the behavioral health workforce. And in the second bullet point, you can see that the Alcohol and Drug Policy Commission is mentioned in Section 6, which is part of this workforce section of House Bill 2086. Section 6 says, the Oregon Health Authority, with the advice of stakeholders and the Alcohol and Drug Policy Commission, may establish minimum rates of reimbursement paid by the authority or by coordinated care organizations to addiction treatment providers to ensure medical assistance recipients access without delay to all modalities of addiction treatment within each geographic region of this state. So commissioners, you should have a good idea here that if this bill were to pass, that it gives the ability to OHA to establish minimum rates of reimbursement, but that they would do that with our input, our thoughts, our opinions, our information, and our advice. As I mentioned, there are many other sections of this bill. We don't have time to go through all of them, but if you would like a fuller description of what is contained in House Bill 2086, please let me know. I am more than happy to talk offline about what is currently contained in this bill. House Bill 2086 is currently in Ways and Means. My understanding is that there is a recommendation from legislators to fund House Bill 2086 at $30 million. And while $30 million sounds like a lot of money, because it is a lot of money, I will also say, just remember, there's a lot going on in this bill. This bill is talking about funding programs, it's talking about reimbursement rates, it's talking about data collection, and a whole lot of other things. So that $30 million is needed. And to go back to something that our chair said previously, I think it's probably also a statement on how we haven't invested in the past in behavioral health. That this $30 million sounds like a lot of money, but it's probably just a drop in the bucket for where we need to go. I think that's about all I have time to say about House Bill 2086. But again, if you would like a fuller description, just let me know and we'll talk more about it offline. With that, I'm going to go to the next bill, which is House Bill 3111. House Bill 3111 is a recovery services focused bill. This bill, as you can see in the first bullet point, it directs OHA to contract with at least 4 recovery community organizations to operate 4 recovery centers, each in a different county. The bill goes on to require to say what the minimum services are that each of these recovery centers would have to offer. But the bill also says, as you can see in the second bullet point, that it refers to the Alcohol and Drug Policy Commission. And the section that is referring to us says, the Alcohol and Drug Policy Commission shall adopt criteria for the selection of locations and local partners of recovery community organizations and the annual performance goals for the recovery community organizations. So if this bill were to pass, we would have some work developing criteria and performance goals that we would develop for these recovery community organizations. There is a fiscal attached to House Bill 3111. There is some costs associated with establishing and maintaining the recovery community organizations. There's also a position that's created in this bill. It would be a recovery manager position at OHA. And there are a few other items that require funding in this bill. So there is a fiscal associated with House Bill 3111. That is why it is in Ways and Means. It's definitely a smaller fiscal than some of the other bills we will talk about today, but a fiscal nonetheless. One of the groups that has really been working very hard on this bill is Oregon Recovers. The last I heard from Oregon Recovers is that the speaker is very interested in House Bill 3111 and is working with others to try and find funding for it. So that sounds very positive, and that the prospects for 3111 look good. All right, I will move to the next bill. The next bill on our list is House Bill 3245. At the beginning of the session, the Oregon Liquor Control Commission said that it needed to have a discussion about how to update its statutes to reflect the fact that the way people purchase and receive alcohol products has really changed over these last several years, and that more and more people are purchasing alcohol beverages or alcohol products electronically and then having them delivered, and that perhaps their current statutes just don't reflect that fact and aren't kind of in that 21st century of how alcohol products are purchased and delivered. So they are using House Bill 3245 to have this discussion about how to bring OLCC and the work it does into the 21st century. There has been a lot of discussion about what should be included in House Bill 3245 and what shouldn't be included in House Bill 3245. But ultimately, this bill does three things. It expands OLCC's minor decoy program. The way that OLCC was reading that statute, they felt it was really limited to brick and mortar businesses. This bill would allow them to do minor decoys for alcohol delivery as well. And the second thing this bill does is it updates OLCC's violation statutes to incorporate those e-commerce businesses. So now if an e-commerce business committed a violation, they would be subject to the same penalty structure, the graduated penalty structure that others like OLCC licensees are subject to. But the third thing that House Bill 3245 does, as you can see in that second bullet, is that it creates the task force on the regulation and enforcement of alcohol delivery by third-party e-commerce providers. Quite a name for that task force. The bill says that this task force, some of the questions that this task force would tackle would be things like, what are the best practices for doing age verification through these e-commerce and delivery businesses? What's the data that needs to be collected or the records that need to be retained when doing e-commerce business? And just the other regulations that may need to be updated or changed, or new regulations, recognizing that we have a lot more alcohol being purchased and delivered through e-commerce. The bill says that there are 14 members of this task force. Some of the entities that would be represented on this task force include law enforcement, businesses selling alcohol through these third-party e-commerce providers, OLCC retail sales agents, and more. The bill also says that there is a seat reserved on this task force for the Alcohol and Drug Policy Commission. House Bill 3245, it only has a preliminary fiscal, as do most bills at this point. What I can see in the preliminary fiscal is that the fiscal is really just the funding that would be required to support the work of this task force. So it probably ultimately will have a smaller fiscal than some of the other bills we're talking about, but it is, as all of these bills are, it is also currently in Ways and Means. All right, we will move on to the next bill, which is House Bill 3377. As I think everybody will remember, earlier this session, there was a bill introduced. It was House Bill 3296 that would increase alcohol taxes. But there was a companion bill to House Bill 3296, and it's this bill, House Bill 3377. House Bill 3377 has been substantially amended from its original form. And so now what's in the bill is that it creates a task force on substance use. And there are, I believe, 23 members that would be on this task force. It would include such entities as treatment providers, public health specialists, the counties, alcohol manufacturers, and more. And as you can see, just like the last bill, there is a seat reserved on this task force for ADPC. House Bill 3377 goes on to say what this task force is going to be doing, what are the questions that it's going to be addressing. And House Bill 3377 says that the task force on substance use, the goals of it are: 1, to reduce underage and binge drinking by establishing appropriate alcohol tax and pricing mechanisms, and 2, fully fund the strategic plan through new and existing tax and pricing mechanisms. This bill also gives the ability to the task force to hire a contractor to help with analyzing data, with doing any of the work that's needed to answer these two questions and ultimately come up with recommendations that would be submitted to the legislature. The time frame for this work is it's short. The task force would need to develop the recommendations and submit them to the legislature by February of 2022. My understanding of this bill is that the recommendation from legislators is to fund this bill at $350,000. So again, just like we've talked about with some past bills, the prospects for it look good. So it is, we have said for all the previous bills, it also currently is in Ways and Means, and I am more than happy to keep everybody updated about its progress. All right, we have one last bill, and that is Senate Bill 755. As I think everybody will remember, Senate Bill 755 is the bill that contains all the legislative changes to Ballot Measure 110. We've talked about Senate Bill 755 a few times in our Public Affairs Subcommittee, and in fact, in our last meeting, we went through what is currently contained in the treatment services section of Senate Bill 755. We don't have time today to do that, so I will just tell you that there are additional amendments being considered to Senate Bill 755, and one of those amendments, as you can see in bullet point number 2, is to add a non-voting seat to the Oversight and Accountability Council that would be for the Alcohol and Drug Policy Commission. Just like the other bills, Senate Bill 755 is also in Ways and Means, and I am more than happy to keep everybody updated with its progress. And with that, those are the bills that mention ADPC. I will stop presenting, hopefully here. And I'll just send it right back to you, Tony, and say that if anybody has questions, please let me know.
Yeah, and thank you so much for that. And we got Ron waiting on us, so we'll move on to Ron. But I would just encourage the commissioners, if they felt so independently, to consider just calling their legislators and stuff and advocating on behalf of those bills. So thank you so much, Jill. Yeah, and Ron, we got Ron Williams here, and a perfect segue from Senate Bill 755. Was it 775, 755? Over to Ron. So Ron, you're here from the Oversight and Accountability Council. You're one of the tri-chairs, and you're going to give us an update on Measure 110 implementation or the OAC, maybe a little bit of both.
Right. Yeah. Hi, Tony. It's good to see you again.
You too.
Thank you, Dr. Richardson, for inviting me. I think it's a great idea for the Oversight and Accountability Council and the Alcohol and Drug Policy Commission to collaborate and do some relationship building. And I'm here today kind of in the interest of advancing that. So yeah, just a little bit about myself. So I'm a person in long-term recovery. I also have a bit of a criminal history from 20 years ago. When I say I'm a person in long-term recovery, it means I've been alcohol and drug free for 22 years. By calling, I'm a community organizer. I got involved with community organizing in 1999. Working for Central City Concern, we started organizing folks in recovery, particularly around the heroin overdose deaths that were taking place in Multnomah County back then. I got involved with recovery community organizing here with the Recovery Association project back then, which led to my getting involved with kind of a broader national recovery movement that was being launched. And in 2001, 2002, I was involved in the launching and the creation of the national organization Faces and Voices of Recovery. I went on to do other organizing. I was a regional organizer with Oregon Action, and then became the executive director of Oregon Action, working on everything from police accountability, racial profiling, green jobs, affordable housing, and health equity, among other issues. Currently working on I'm going to switch just to give you a little background, kind of how I, prior to this year. So when I saw the opportunity, because recovery advocacy and recovery organizing is in my blood and something very close to my heart, when I saw the applications, when I saw the opening to be involved with the Oversight and Accountability Council, I was really honored that I was appointed to that council, and I'm able to move this what I consider a very important and innovative and strong law that'll make a real difference for the people of Oregon. So the Oversight and Accountability Council, I'm not going to go through the law or talk about the components of the law. I think most people are familiar with it, but I just want people to know that the council itself has very specific responsibilities, and those responsibilities primarily are to create rules and requirements for recovery services grants that are funded with cannabis tax revenues. It also, the Oversight and Accountability Council oversees and implements grants and contracts to community-based organizations and governmental entities, and I think now nonprofit and for-profit organizations who deliver either recovery services under the increased access to care grants or the behavioral health, what are now being called behavioral health resource network grants and contracts. And when I say behavioral health resource networks, that language is in Senate Bill 755. It's amended language that changes from the original addiction recovery centers. The Oversight and Accountability Council is able to enter into intergovernmental agreements. It can revise and adjust rules as needed, and it can evaluate and assess performance of the behavioral health resource networks. So that's fundamentally what it does. The council has a really wonderful and diverse makeup. It's primarily people with lived experience. There are 18 people identified as Black, Latinx, Indigenous, Native, or Tribal. I think there are 2 folks on the Alcohol and Drug Policy Commission, Morgan Godwin and Caroline Cruz. They're also members of the Oversight and Accountability Council. If they're here, I want to say hello to them. So there's tribal representation on the council. There's a lot of geographic diversity. 9 members are from the Portland area. 12 members are from outside the Portland area. We have folks from the coast, Lincoln County, folks from Grand Ronde, Willamette Valley, Benton County, Marion County, and other places all around the state. So there's quite a bit of diversity geographically and ethnically on the council. So so just kind of walk through some of the activities that we've done. So we were stood up we began meeting, we were all appointed. We had, the law required that the council be stood up by February 1st, and that took place. We began meeting the first or second week of February. One of the things that we did initially was elect co-chairs. We elected tri-chairs. I'm one of the tri-chairs of the council, along with Lakeisha Dumas, who works for Oklahoma County. I believe she's also a board member for Brown Hope and also Oregon Recovers. And we also have Sabrina Garcia from Southern Oregon. I believe it's Transformation Recovery Services, if I have that right. So those are our tri-chairs. That was one of the first things that we did. We were elected by our peers, and I'm proud to serve in that capacity. So one of the first opportunities that we engaged in was an opportunity to engage with the Senate Committee on Judiciary and Ballot Measure 110. They had developed these, they had a main work group and then a treatment services work group and a courts and law enforcement work group. And people on the council self-elected or self-appointed themselves based on an invitation or a proposal from OHA to the Senate committee that members participate. So there were about 9 or 10 of us that participated on the Senate committee, kind of informing the decision-making that went into the decision-making that went into the amendments that were ultimately included in the law as changes. As Aaron said, that Senate Bill 755 makes style and form changes, adds detail, and increases and adds clarification on many of the sections that were left silent and that sort of thing. So we spent a lot of time kind of informing that process, and that was kind of a major part of what the council did. We had some discussions on some amendments. We had Leslie Wu come from the Senate committee and present. We're going to probably have her come back real soon to talk about kind of the final versions that we're hearing. The other thing I'll mention is that kind of halfway through March, we got the Speaker of the House, Tina Kotek, sent us a letter basically sent us a letter that she CC'd the council, basically letting the council know that she was directing the Oregon Health Authority to distribute $20 million in funds of the cannabis tax money, cannabis revenue under Measure 110 to get money out either through contracts or grants right away. And so that process began in March. And the council's role in that was we created values that then informed the grant application process, where members of the council sat down with subject matter experts within OHA and developed a grant proposal process using the values that were created by the council. We spent we spent a couple of meetings, council meetings, talking about.
Ron, Tony, real quick, I just want to let you know you're at 5 minutes. So if you wanted to discuss with the commission, we'll start wrapping it up.
Yeah, I am wrapping it up. This is the wrap up right here. So, so what happened was so as a result of that process, we were able to get the values inform the grants. The grant application went out. The RFP went out. OHA received over 115 applications, totaling over $40 million in requests. The amount that was available for granting ended up being $10 million after contracts and carve out to the tribal communities. And so that happened like a week ago. And so it just kind of goes to show that there's a tremendous need. There was a tremendous response. It was overwhelming. And going forward, where we're at in terms of the council is that we're in the process of right now, what we're doing is we're engaging in the rulemaking process. We have a decision-making process where we're looking, where we're determining kind of the parameters for the behavioral health resource networks, or peer-delivered services, harm reduction, housing, and low barrier access. We've already completed kind of a decision-making grid on the burns and piers and harm reduction. And coming up next, there's going to be a full discussion on to develop a decision-making grid on housing and then low barrier access treatment. So that's kind of where we're at. The only other thing I was going to mention was the actual rulemaking process. Should culminate by September 1st with another grant cycle taking place around that time, with additional funds going out in February. That's kind of where we stand right now. Any questions?
Yeah, thanks, Ron. So that was a lot, but thanks for the update. So does the commission have any questions, within the next 4 minutes?
I do know that was a lot. But,
So it appears to me that, having Reggie sit on every committee there is based on the legislative concepts that just came through, that you and him could potentially be working together, or some iteration of us and you guys, and potentially we can start, crossing stuff out of our plan. If there's communication saying, hey, these things are getting done, so, the ADPC can then focus its energy on other parts of the system that may need, additional advocacy or attention or something like that.
That's absolutely right. We had a presentation about a week ago from the Alcohol and Drug Policy Commission. Dr. Richardson and Caroline Cruz presented, so we're able to.
Hey, can somebody mute?
So we actually got a presentation a week ago, I believe, from Dr. Richardson and Caroline Cruz, and we're able to actually see some potential places for collaboration and coordination and communication to increase between the two entities. And so yes. And one thing I'll just say, just listening to kind of what about the SUD waiver. We're really in an exciting time right now where there are lots of things happening. We're kind of operating from a place where it feels like there's some great opportunity to really make a difference, really expand services on multiple levels. So all these things come together right now. We're in a great place, I believe, in the state of Oregon.
Hey, Chair, I just want to say to Ron and to let the rest of the commission know that in our effort to, coordinate, Ron was the first to really reach out months ago to me. And so the invite to his meeting and then his coming today, I think, is the steps in making sure that we're all on the same page, rowing in the same direction. So I just want to say publicly, thanks for your outreach, Ron, and the work that you guys are doing. And we look forward to being able to work together, both the council and the commission, in our activities.
Okay, thank you, Dr. Richardson. I feel the same way.
Thank you. Okay.
Yeah, thank you very much. And thanks, Dr. Richardson, for sitting on all those councils and stuff that you get put on. We may need to request the governor to up your budget to get you more support staff. I know how hard it can be to get everything done. So if there's no other questions, thank you, Ron, and then we can move on to our next presenter, Heather. And hope you'll come to these monthly meetings as much as you can, Ron.
Yes, we'll probably share the load among the tri-chairs, but absolutely.
Okay.
I just wanted to say thank you, Ron. That was good because you guys have been doing so much work. It's just immense. It's an immense amount of work. So thank you for everything that you guys are doing. Hello, committee members. My name is Heather Jeffress. I am the Executive Director of the Oregon Council for Behavioral Health. And thank you very much, Dr. Richardson and Chair Venza, for inviting me here to talk a little bit about what opportunities and challenges for providers of services for substance misuse and substance disorder here in the state of Oregon. So I just have to reiterate, I agree with everyone here about good news on the horizon. And I did want to take a moment to thank everyone here on the Alcohol and Drug Policy Commission, because I do think that the conversation that has been happening in this body has been a big part of providing the information and education that has been part of informing our leadership and bringing the issue at hand to the place where it's at, where we actually are starting to get some actionable activities. So thank you for your work and your volunteerism on this body, and for the plan development of the plan, and all of the things that have been happening here at the commission over the last bit of time. I do think it has been a big piece of just elevating the conversation and getting us to a place where there is some pretty exciting, actionable activities occurring across a variety of bodies that seem to be talking to each other, which is, in my 25-year career here in the state of Oregon, in the mental health and substance use disorder field, is an exciting occurrence. I'm excited. So thank you very much for that. I just wanted to talk a little bit. The Oregon Council for Behavioral Health is a trade association. It's comprised of over 50 member organizations. Members in our organizations are state letter of certificate holding entities, which means they have a state letter to provide some kind of a Medicaid service. And then we also have other members who are not full members, but affiliate members who do services that don't necessarily require a state letter of certificate. But the larger proportion of our membership and the work that we focus on is really in that clinical sphere of outpatient, residential, and other Medicaid billable or commercial billable services. Our largest member, those would be like Central City and Cascadia, which have almost 1,000 employees and serve several 100,000 people annually. And our smallest members have maybe 2 employees and serve a huge amount of people with 2 employees. So we have a wide diversity of sizes and service elements across the state of Oregon. So when I'm speaking from a provider experience, that's really what I'm drawing from. But I would say our membership in size, geography, and then also in culturally responsive services, it shows a spread. We have folks that do immigrant services, who do tribal related services, who perform Latinx services, and they do try to be as linguistic available as possible, and are always working and striving to grow access for those services, African American specific services across the state of Oregon, based on community need. So we do have a wide scope of folks doing a wide scope of work, and I will try to focus on the substance use disorder because they all also mostly do some mental health too. But that is one of the trends that I'll talk about that we're seeing, and probably to many of you won't be surprised, because co-occurring work, or as we used to call it in the old days, dual diagnosis, has been a long standing need in the state, and something that has been discussed and strived for my time in the field, for sure. So what we're really finding is, we entered the COVID pandemic with particular struggles, and those have not left us. Those include workforce struggles, trying to tool the system to be more responsive for co-occurring, tooling the system to be more health lens focused versus criminal justice focused, and also really trying to get some traction to do some retooling around youth services, which have really lingered horrifically in the state of Oregon for the last 25 years. And then also, just really trying to find a way to deal with our under-operationalized systems. So what I mean by that is that because of those historic funding systems for substance use disorder, particularly coming out of the charity care history, we really have huge struggles for having infrastructure that includes technology, ability to pay better wages. These are long-standing issues well before COVID that were part of our system and part of how it was developed, that really are the results of the impacts of being seen as charity care, which includes stigma and population racism in the development of these service elements. So, these are not new things to our sector, but COVID has really exposed this to a whole nother level, right? So, these are things that we will continue to struggle with, but we do see there is actionable traction happening to make change in this, and this is very exciting. So we're very excited about the future. So when I'm going to tell you some Debbie Downer stats on where we're at because of COVID in regards to access and workforce, we are doing our best to, as a membership across the state, to cobble things together, to use this time as a time to innovate, to overcome challenges and be creative, because we are creative as a sector, I would say that for sure, and to hold fast until we can get those resources at hand, because as Joanna very nicely said, these things take time, and we know that we probably won't see significant investment to support things till a few months down the road. So what I'll do is I'll go ahead and share. So you guys, please interrupt me at any time if you have questions or anything. I just wanted to kind of give you an overview of the perspective. I love questions because it helps me think about things in a more accurate way, because I'll just be honest, it's a busy world out there and my brain is a little mushy sometimes. So, one of the things I'm going to talk about today, and I sent a report to Heather to share with all of you, is that during the COVID emergency, we've been doing a sustainability report with our membership. We're also part of a national group, and we've been providing that information to that group. And so that data has really been used with our leadership in the state and at a national level to really bring some excruciatingly needed resources to the substance use disorder providers and mental health providers in cash to ensure that they can keep their doors open. So we got provider relief, worked with the team over at OHA for residential facilities, which is an empty bed payment. We're looking at a one-time allocation from the e-board based on the collection of this data and other information and our great partners at OHA, and approval by CMS. You learned all about that earlier from Joanna. To provide a one-time 10% rate bump to also alleviate the extra costs related to COVID. Without those two state items, the numbers I'll share with you in a minute about access and capacity for the residential SUD sector would not be even as good as I'm going to share. We suspect without those rate bumps for the empty beds that had to be empty due to social distancing, there's a possibility we could have lost about 50% of our programming across the state due to COVID. So, there's been some really critical, and then there was some critical investments that actually federal dollars came directly to providers, which is unheard of. But we actually received direct payments through Medicaid process and the USHHS to our providers, which was pivotal and critical in helping them sustain their capacity. So there's been some good things that have happened to keep people floating along. We're super excited about the future, and we think that there's some wonderful things that we're looking forward to. So some of the things that we're doing as a sector while we're waiting is really diving into looking at delivering care in different ways, and how can we use that to increase access, equitable access, linguistic services, and also improve the sustainability of the nonprofit and private providers who provide substance use disorder services in the state. Both to, we often forget our members do a heavy bit of Medicaid business, but they also do commercial billing. And we have members who actually do more commercial billing than they do Medicaid. And so how do we diversify so that we can make sure we have the most access as possible? So some of the big initiatives that I think were talked about in the legislation right now is telehealth. Telehealth has been a lifeline for outpatient care and keeping outpatient therapists employed and providing access to consumers. I think as Commissioner Carolyn was saying earlier, we'd all prefer to be in person. But telehealth is what we do because that's what we have to do. And telehealth is only stayed at 50% of on average. So, we're still 50% below what we used to deliver in person before COVID, but it is better than not 50%. So, and then we're also learning which folks are really doing okay with telehealth. Some folks with really severe anxiety actually prefer it, but many, many, many folks really are longing for face-to-face services. And for our folks with really significant challenges, face-to-face is imperative for them, both on the mental health and SUD side. So we will be looking forward to that, but we appreciate that telehealth is now an option, and it's an equitably paid for option, and there will be pay equity for behavioral health, telehealth into the ongoing future due to legislation here in Oregon. So we're very excited that gives opportunity. I don't think we would have ever gotten as far down the road with having the extra tool in our toolbox of telehealth in the way that we have without COVID. So that was a tiny silver lining, I suppose, to the emergency on the telehealth side. So our members are doing quite a bit of work around developing telehealth divisions, working with workforce who prefer to work from home and enjoy that flexibility, because we have to do everything we can to retain our workforce. So if that means someone needs flexible hours and prefers working from telehealth, I think we have the capacity to continue to do that for them, exploring many, many different opportunities now that this is available. The other thing that folks are really driving in the field to do is integration. We found that our members who had integrated mental health and SUD services and physical health, because there are many of our members who do some kind of physical health, or they streamline and partner or co-locate with a physical health entity, whichever model providers are doing, they found that actually that has been helpful in sustaining their service elements and their structure during a crisis. So that has been an interesting lesson learned, and also to help coordinate care for individuals. So that's pretty exciting. We were all really believed in that model, and we are learning that it actually had some extra benefits we would never really thought about in a crisis situation. So things like the CCBHCs, the Community Certified Behavioral Health Centers, folks who have federally qualified health centers, folks who are co-locating with hospitals and emergency rooms, all of the agencies who are able to diversify and partner and incorporate that physical health are really finding surprising benefits and ability to really move to the healthcare lens and improve access, especially for co-occurring folks. And then the other piece that we are finding in the emergency is co-occurring is so prevalent, as we all knew, but our folks with co-occurring are really what we're seeing in the highest acuity in this first wave of what we expect, because now physical COVID is abating and getting vaccinated, and we're excited about that.
And Heather, we're at 1 minute.
Oh, 1 minute, sorry. So the other trend that we're finding is that we're just at the beginning of COVID behavioral health impact. So our folks who are more vulnerable, have more instability in their life, they really are on the leading edge of what we expect, and we're seeing discussed at the federal level and various state levels that over the next 2 to 3 years, we will expect a great surge in the need for behavioral health services, SUD services, and particularly co-occurring services. So all of these pieces that we've been working so hard for all these years, thank goodness we were doing it, because as things abate on the physical health side of COVID, we are preparing for a large amount of need that will not be abating for some time with behavioral health. So we appreciate all your input and your work around this. So I don't know if there's any questions, but that's a little snapshot. And I'll send that report over for Heather to share with you. And we're doing our third report where we will include workforce issues. And I can just run through. Tony, do I have time to run through just a couple little data points?
Well, I want to be mindful of public comment because people may be on who've waited. So I think, thanks for the update. We could continue discussion if there isn't public comment. Yep. But I would say that for me personally, one thing we may consider doing is figuring out how the ADPCs policy authority or influence potential can partner with you in executing our plan and making the system better and building that relationship with you because you have a lot of insight to how we can operationalize our plan and affect good change.
No,
So,
I totally agree with you. And I think, as I mentioned, as I started off, the work that was done on the plan has been a big piece, I think, of many of the initiatives that have been discussed here today and can leverage some of the trends that we're seeing in the system currently. Yeah, so I appreciate it. And I'll send the data points over for you guys to look at on your own time.
Appreciate that. If you have any of OHA's data points, set those too. I'd like to open up it for public comment. Is there anybody here who would like to give public comment?
Hey, Tony, it's Mike Marshall with Oregon Recovers. I'd love to just weigh in real quickly if I could.
Yeah, go ahead.
Thank you and congratulations, Tony, on becoming chair. It's exciting. A couple things, and I apologize, I missed some of Jill's presentation, but the latest news as of today is that in collaboration with us, Representative Solomon is withdrawing her bill that originally would have required 2 of the 7 OLCC commissioners have a public health background. We had agreed, she had agreed to amend it in the Senate to take it down to 1. We had the votes lined up, and then some folks talked to Democrats and Republicans over last weekend, and we lost the support we had for it. Senator Anderson was going to make an amendment that required the OLCC to study themselves and decide whether they should have changed the makeup of the commission. And we, Representative Solomon, decided that probably is not the most effective way to address this issue, and instead would bring it back for the next session. It's obviously very, very disappointing. Alcohol will kill 6 people today, and then again tomorrow, and then again the day after. That's a 34% increase, as you all well know, over the last 20 years. And the OLCC has never even had an agenda item to address that. And that's largely because the people at the table are not bad people, but they're there to represent the industry. And I think it's telling that some of the Democratic senators in particular, but Republicans as well, were arguing that the sole purpose of the OLCC is to sell alcohol and generate revenue for the state. And, I think it's telling that I believe the legislation passed, but I'm not sure, but that they changed their name from the Oregon Liquor Control Commission to the Oregon Liquor and Cannabis Commission, because cannabis is now a part of their mission. However, the control aspect is what they were set up to do when they were established after, I don't know the long history of the OLCC. So it's obviously very disappointing. That said, there's been a tremendous amount of conversation within the legislature, within the stakeholder community, within the peripheral stakeholder community about the impacts of alcohol, how it's a driving force relative to underage drinking and binge drinking are the 2 leading contributors to our high addiction rates. And so, for 40 years, no one's had that conversation in a meaningful way. And then the other part of that is House Bill 3377. And I, sorry about the dogs. Jill, I don't know if you talked about 3377. Okay, so I will leave it at that, other than we're still alive and we're optimistic with the speaker support that we will get out of Ways and Means. I am not optimistic that there won't be an effort to kill it in the Senate. This morning, the wine producers, who the vast majority of them are exempt from the excise tax, so it's really not relevant to them. But they sent a letter saying that the idea that the study has to address reducing underage drinking and binge drinking by raising the price is a preconceived notion of what should happen. And they are correct. One of the most effective prevention tools is pricing. And so we have to have a meaningful conversation about that. So,
and Mike, your 3 minutes is up. There's 3 minutes per person.
Yep. Thank you. Contact your senators. 3377.
Yeah, thanks for all your hard work in the organizing, Mike. Is there anybody else who has public comment? And Dr. Richardson, if there's no other public comment, can we open up for discussion, or is that something we can do?
Yeah, absolutely. You have, we're ahead of schedule by a little bit, so yeah, we definitely can do that. So feel free.
Sure. So just for the other, commissioners here, I think for me, what I would like to see us do every commission meeting, either collectively, or individually, is take some sort of action, have some sort of action orientation to what we're doing. On an individual level, what I'm going to do is, I'm going to contact my legislators about various legislative concepts, bills, and stuff that are in alignment with what our mission is. And then I'm just wondering if, other commissioners have ideas of actions that we could take based on today's discussions or previous discussions.
Hey, Tony, this is Pat Garrett. I just want to clarify before we get off that you want commissioners to provide Dr. Richardson with maybe some times we would not be available for the offsite, perhaps in the August-September timeframe.
Yeah, I mean, you could email that in, like sometimes that you would not be available. That would be okay. And Caroline Cruz, I've seen your hand pop up.
If you're speaking, Commissioner Cruz, you're on mute.
I'm back. Okay, I just like to invite the commissioners to the Tribal Opioid Training Academy that's going to occur June 15th, 16th, and 17th. And I will send that link to you, Dr. Richardson. It's all virtual. And so we're going to have a variety of topics. And even Tony is one of our presenters. I believe he's going to do motivating interviewing. So I just like to invite all the commissioners to that academy. And I'll send the link to you, Dr. Richardson.
Thank you. And I'll send it out to everybody. That sounds really exciting. Also, Lines for Life is also sponsoring a conference. I sent that out to you folks earlier. So it looks like we've got some good stuff coming up this summer. Thanks, Commissioner Cruz.
And Nate, did you have anything you wanted to add as the vice chair? Me, you, and Rich, Dr. Richardson have been working together really well. So I just want to get your perspective and insight and any input you might have.
No, nothing to add from me.
Okay, well, we'll see how good my motivational interviewing skills are as we move along this thing. Getting people motivated. Dr. Richardson, what about you? Anything that you need from the commission, requests, information you think would be useful to us? Any support we can give to you?
Not that I can think of at the moment. I would like to just take the opportunity, if there are suggestions that commissioners have for improving our agenda, if there are things that you'd like to see on the agenda that you haven't seen, or you'd like to make suggestions about how we might do things differently, we are always happy to hear that kind of feedback. Also would like to take the opportunity to thank our chair for running this commission meeting with its efficiency and poise, and it's fun to work with you, Tony. I appreciate having you as our chair, and look forward to what's coming in the coming days. So thank you. That's all for me. I appreciate it, everyone.
Yeah, and Dr. Richardson, you froze, but okay, you're back. Yeah, appreciate working with you too. I look forward to the commission, taking action. I think one thing that we could consider doing is kind of mapping out our plan in relationship to all the funding that's going to come. I was on a national call around advocacy efforts, and it looks like the Biden administration is proposing to dump a ton of money in the treatment and recovery support. So that looks good. And I think, you know, what I've seen today is the commission be a convener and organizer to disparate efforts in the past. And since I've gotten to this work, that's what I've noticed. There's a lot of fragmentation, good work going on, but fragmentation. So anyways, you know, if there's no other comments or whatever, I would propose that we close the meeting a few minutes early.
Great. Thanks, Chair. Thanks, everybody. Thanks, commissioners. We'll be in touch. Everybody be safe. Goodbye, everybody.
Thank
Bye.
you.